So Dr. Young, start us off. Tell us something cool. Give us some rave, something new that you've been playing around with that we'd love to know about.
Well, I can say that, I mean, we never thought I was probably the hardest core guy that I'll never go to a one bottle, a one component bond. But I will tell you, I know Ferrari's just released UBQ2. It'll be presented at CDA. And in that bod genre, it's handling really incredibly well for your, things that aren't too critical. When I'm deep in dentin, I go to to SC Protect or SC or something else, but it's handling incredibly well. And I think for a lot of dentists, it's going to be great.
Repeat the name of the product for
you.
Repeat the name of the product for the audience.
Quick, but it's the version 2. I'm not going to get into the details on it, but it's they've thinned it down, and yet
so it's a single
strength.
It's a single component bonding agent that you've been using. Okay.
Yeah.
And you etch the enamel or not?
Beg your pardon? Etch? Yeah,
you etch the enamel or not?
You do, but it's set up. The reason it's kind of interesting is it's kind of no-brainer for it'll go no etch, selective etch, or total etch. So we know in dentistry it's hard enough to get people to selective etch, and then other times they won't forget to write any etch on. So kind of covers all the grounds.
Yeah, okay.
And the bond strengths have been showing to be really, really good. We'll be putting it out for the CDA meeting, and handled really beautifully. And it's, we'll see. The bond tests are showing really well.
Okay, so question to you. So you're doing that for direct, it sounds like. Would you use it for your indirects?
Yeah, for the indirects? Yeah. So you can use it with their Panavia, their regular, the blank of the name. It'll kill me. Panavia SA cement. So if you want to increase the bond strength of SA cement, you can use it for that. That was what it was really designed around. So you can improve that bond quite a bit as well. I think the biggest thing with their product was the amide monomer that doesn't require you to scrub for 20 seconds. It's a fast, quick bond technology to dentin. So we're doing all we can do to get people to scrub for 5 to 10 seconds, leave alone 20. And
when you say, I'm sorry, you said MI technology, if I heard you correctly?
AMIDE. It's another patented technology.
Amide.
They've replaced HEMA.
All right.
You have that in the one if you've played with UBQ, the regular, that's the amide monomer. But they added another proprietary material that reduces the thickness without losing any further bond strength. So that's another proprietary material of theirs. I haven't put it to memory, and that'll be introduced. But it's just, when I think of that material in these one bottles, it's pretty scary with them because there's handling characteristics that need to be followed. And when you look at big clinics and with composite dentistry, one of the biggest issues is handling the bonds correct. And we know that for those of us who have been, etching dentins since 85, scrub times, all of that was super critical. So this UBQ product, so that's kind of the new one that I'm seeing. It'll be introduced in CDA. Like everybody else, they brought out a one shade that's covering. Well, there's 2 tubes. It's a universal and a universal UD, which goes for A3.5 and deeper. And that's a great.
So I'm a little unclear. So there's a bonding agent and a separate composite with the system. So you got two. You got a bonding agent, a new bonding agent, UB2.
Yep. UBQ2.
And then
they've released their new ES Universal Anterior Composite. And that will be presented at CDA as well. Like everybody has a universal. They finally brought out their anterior universal. And it comes in 2 shades. It's just U and then UD, which is for darker. Looking good. It handles really well. It handles beautifully. It's a flowable that's actually a stout. You can cone it up. So it handles really nice in that sense. You can put it where you want. It's got a little more viscosity to it. And so the handling of it was beautiful with class 5s because you could just move it where you wanted it. So far it looks good. So those are some.
So the idea is it's a flowable material, the composite part of it, and does it have a more viscous, pasty system with it?
That's the feel of it. Yeah. So you could actually ice cream cone it, like you put it up down. You can create a little ice cream cone with it.
Okay. So it's kind of between what most people would think of as a flowable or a paste composite.
Well, yeah. The problem was, some flowables are too flowable, and others are less flowable. So it's kind of a perfect feel for what it's designed to do.
No, I was just going to say the recommendation of it is class 5s, black triangles. It sounds like. Are they recommending it for?
Yeah. Any anterior where you would use an anterior flowable.
I was going to say I wouldn't use a flowable for a class 4, but for the other uses, I class 3s, class 5.
Correct. Class 3s for sure. And I think it'll be nice with black triangles, because its ability to pull the color. So we'll test it on that.
Great.
It seems like it's higher viscosity.
Small class 2s.
Yeah. Well, they have a exterior universal.
All right. So
yeah. So that's that.
So so would you give it? Okay. So remember, we got mostly probably general dentists listening to us in the lab, some laboratory people, of course, because we appeal to that audience, and some patients too. I hate to use the word caution, but how would you recommend somebody maybe to try this material?
Which, the flow or the both?
Well, the bonding agent and the flow. Yeah.
So the bonding agent itself, my rule of thumb with any of these one bottles, is I have two basic bonds that I use. I use SE Protect, where I have deep dentin, a lot of dentin, where I'm really concerned about stresses and that. And then for your smaller restorations, shallow class 1s, class 3s, shallower class 5s, the UV Q2 is going to be really nice, especially in in like black triangle work in the front. Its thickness, it's not as pooling, so it handles really well up there. So the composite itself, I think, is great in class 5s. The only thing with any of these universals, I tend to, some people call it immediate dent sealing resin coating in these deeper class 5s. So what I do for that resin coating is I use a more opaque flowable. And that's, I think, with any of these, so that when you lay your final layer of this universal, you're going to pull color from around the enamel, but you'll have masked out some of that deeper, dentin area. So I guess it's a nice material.
Okay, great. So Dr. Young's Rave is a new material to look at from Kura/Noritake. It's a combined company, a new universal bonding agent, and a new sort of semi-flowable material that's a unishade material. Great. I'll give it a look, buddy. And let's move on to Dr. Ortiz. What would be your cool new Rave for us?
Something that we might look into future episodes for a literature review, which is telegrammetry.
Okay.
Photogrammetry, I'm sorry. Photogrammetry.
Photograph, yeah.
Which, for those of you who don't know, one of the problems that we've been having for the last 10, 15 years so since we have dental scanners is that the normal, regular intraoral dental scanner will take a million different pictures as you move and they try to stitch them together. And that stitching is proprietary for each company and how these pictures are put together to create a three-dimensional image. That stitch has always been the weak link, right? We have 10, 15 years of studies saying which is more accurate and precise, is there three-dimensional distortion, blah, blah, blah.
Brilliant.
And even though scanners have gotten good enough that we're not talking about it anymore, how good a scanner is, because they're all good now, we still know that if we want to do full large implant restorations, a little bit of three-dimensional distortion will give you trouble, especially if you're doing a zirconian rigid that you try to seat it and then you have to verify the cast because it's not going to seat or it's going to put stress on the screws, restorative screws, whatever. So what seemed to be the solution, which is to wait for the scanners to get better, jumped immediately into a different type of scanner, which is the one that you people maybe have seen, that people put like these little domino things in the mouth. And now you get this machine that from the outside of the mouth will read all these little abutments or scan bodies with domino-looking dots. And in 2 or 3 of the pictures that it can capture all of them at the same time, it will capture the position of all the implants with respect to each other with tremendous accuracy and precision. You don't get the intraoral tissue with this one, so you will still have to scan the tissue. But I've been playing around with this technology in the last few years, and when you begin, you don't know what you're doing, and with the help of Miss West Dental Arts and Ibiza Dental Lab, I've been playing around with it, and I've been getting very good results to the point that you can do large cases in which you're doing an L4, an L6, or implants that are already there. And it takes literally like 5 to 10 seconds. It goes like beep, 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 beep. It captures all the implants. Now you have them in the computer, and now you can scan intraorally the tissues or the intaglio of a provisional denture that you have. And you can, within minutes, merge these 2 together, and now you have a final impression of implants that I know by fact because I've seen it in my own practice, and I also talked to Dr. Sinara, who's been doing it for a long time in Arkansas. You don't need to verify the cast anymore. There's no cast verification. This thing is accurate enough that now you can 3D print your provisional full arch. You can send that to the lab and make it out of zirconia. Funny enough, I use as a guinea pig my father-in-law, who lives in Canada. So my father-in-law has had compromised health. So coming to the United States is very nerve-wracking for him because he doesn't have health insurance, and if anything happens, he's trapped into the system. And he needed a full mouth reconstruction, and he came in for like a week, and I did that. I did exactly that. I extracted everything that needs to be extracted. I did all the implants immediately with the photogrammetry, did everything I had to do. I 3D printed temporary full arch for him, but I knew the next day I had the final zirconia, and I went directly to final with the implant that I had placed 2 days ago, and it just sat so beautiful. And I got lucky and the occlusion was okay, so I didn't have to deal with that. So I am impressed to out of war with this technology that truly came to solve a big problem that we have, and it makes the process of delivering a full arch restoration seamless. I can tell you guys, I will never in my life convert a denture chair size ever again. I don't want that mess. I don't want that experience. I don't want nothing to do with it. I'm done converting a denture, cutting it, making holes, picking up no. So I can go like this, and within 45 minutes, I have a perfectly tissue design provisional that goes in the patient that I just need to screw in. And that's the combination of photogrammetry and 3D printing. Sorry.
There you go. My question, my understanding is that the specialist, so for most of us that don't place our own implants, the photogrammetry would be at the specialist side, correct? So if it's your periodontist or whoever's doing your implants for you,
it will be great if they can take that. It takes, like all they have to do is after they put the implants and the uni abutments, put the scan bodies and scan, even if they're not going to find it. It would be great if you specially can do that.
That's who has the technology generally, as my understanding. Because my roommate in dental school, Curtis Pond, and he works with a periodontist that has that in-house, so that they're doing it. So that's my understanding, right? It's whoever's placing
it. It's dropping in price beautifully. It's dropping in price beautiful, that technology. Blue Sky Bio, I just got an email or something, a notification for that this week. They're releasing their own, or whoever they're collaborating with. I think it's like $13,000. Yeah.
And so it's dropping. So to summarize then, the basic point is that imaging technology, whatever we want to call it, programmetry or any sort, is getting so good that we can do this stuff at a very high quality in a very short turnaround time, and eliminate some of the big messy procedures we have to do with things like viscogel in the past. Oh, that's great. Okay, so my rave would be, and then we'll do a rant, and we could rant forever, I suppose. And I won't take more than a couple of seconds because I've just been so impressed with what I've seen with the evolution of resins. specifically with the development, a little bit of input on my part, but the guy we're going to interview in just a few minutes, Jed Archibald, who's going to share what he's doing in the development and put his own time and money. I helped a little bit, but it was really 95% him, develop really resins that have amazing physical properties, at least for a cast, maybe not for the mouth, but they basically look like stones. So that would be what I would like to focus on, and then we'll do that in a couple of minutes here, that interview. So let's move into, and I wrote a couple of things down here. Sorry, I'm looking at my list of stuff here. A rant, okay? And I got like 50 rants and one rave. Maybe it says something about my personality, but I've been seeing a lot and been asked a lot recently about what is a holistic / detox dentist / the bio whatever dentist. And interestingly, that term, okay? And then now I'm hearing a lot of people talk again that we talked 20 years ago about cavitations in bone, and where people have had wisdom teeth out and that it's never healed, and that's created all kinds of systemic system problems, even like an autoimmune disease or something like that, which I'm not discounting as a possibility. Or more recently, it's starting to cycle again where people are saying they would never do a root canal. Everything is an extraction if a tooth needs a root canal, because root canals don't work, and placing implants. So my rant about that is, and I would recommend people look at recently Marcus Blatz posted a paper, and it's up on his Instagram, a very good review about the success or failure of root canals versus implants. And actually in this review, I believe it was from roughly about 10 years ago, root canals actually survived a little bit better than implants done exceptionally well. So, and there's an interesting point about that. Should one or the other be the treatment? In my perspective, I would do the least invasive treatment, and then if that doesn't work, we can always move on to the next treatment. I saw some guy on the internet saying 90% of root canals that he does fail. Well, I'm guessing that 90% of everything he does fails, okay? And I can tell you well-done root canals, and I don't do root canals. I have endodontists do them for me. I see extremely low amounts of failure, extremely low amounts of problems. And if we end up losing a tooth or two occasionally, fine, we can do an implant. And what people forget, they say there's bacteria around, because the dental tubules we don't completely seal off. There's 40 trillion bacteria in your intestines. Not all of them are good. And it's the same thing around a periodontal ligament. You have a few bacteria. This is normal. This is a human biologic or a biologic process. The problem is when too many bacteria overwhelm the system to be able to deal with it. Yes, we need to do that. We need to do something then if we can't keep a healthy biologic around a tooth. But also we look at implants. You can put an implant in. There's an oral connection to an implant. Sometimes that interface fails, where bacteria get around that interface. And when you see implants fail, the bone around there, the failure is miserable sometimes and very, very problematic to correct. So any audience that we have watching out there, whether it's a general dentist or hopefully we have some patients, a well-done root canal by a qualified person, doesn't have to be a specialist, but a qualified general dentist on a tooth that should be successful is really the way to go. So sorry about my long rant, but I get very concerned about some of these things I see in dentistry. I saw some dentists today. It's this social media thing is so fascinating on both levels. We talked about that on our first show. We're talking about that the shape of your central incisors and the relationship of your incisors is related to how your mother or father treated you. So if they treated you nice and you were at a good relationship with
that
your
is
mother,
true. That's been demonstrated. I have friends that the parents smack their front teeth and they have the size after the smacking.
that's different. Okay,
So there are really...
no. I'm not talking about trauma.
If my dad, when he used to hit me like this...
That's a different. No, I'm not talking about a traumatic development.
Oh!
I'm talking where there was trauma to the tooth. I'm talking where if your parent was a certain type of personality, they were a little bit harder on you, your teeth developed differently. It grew differently. Not talking about a physical process. Someone was
Can you imagine if that turns out to be true?
Well, okay, come on, man.
I want to push back on the root canal. I'm going to rant on your rant. Can I rant on your rant?
Your plea, that's why we're here. That's why we're here. Go on,
I
Miguel.
think that there is something about root canal conspiracy that might be true. Something, not everything. I'm not against root canals. I think the science is solid. But I won't put my hands on the fire to say that 50 years from now, we're going to be looking back at root canal and saying that they were as good as we think they were, as everything else we're doing.
I'm not just, I don't disagree with.
I think we're putting something that is not from the body, in the body. We're not really fully cleaning it. I did root canal research I actually did this. This was my graduation research in Harvard because I realized a month before graduation that I needed a project to graduate. And I went to the end of the department and I did 100 root canal, 50 on a sterile surgical environment and 50 without. And then we looked inside and they were all contaminated. But the idea that we can just put something in there, a filler, on a tooth that now has no innervation or vascularization, and that because our measure of success and survival in dentistry says that it lasts, that is good for the systemic body, I'm not going to put my hands on the fire for that one. I can see how if we go and analyze the tissue right around periapically, man, there's a bunch of stuff.
Okay, so what I think we should do on this...
But now with CT, yeah, let me push back for a second, then I'll let you in, Richard, okay? With now computerized CT technology, we can look around a tooth, we can look, say, and if we don't see any signs of inflammation, okay, we don't see any signs of bone loss, we see healing of a periodontal ligament, okay, then what is the alternative? The alternative is worse. I'm not saying it's perfect. I'm just saying the alternative we have today, extract a tooth, do a bridge, which is very damaging to the adjacent teeth, okay? And or an implant that is not 100% successful, the bone around it, you still have an oral communication. Yeah. Yes, we need to be able to do that on teeth that we determine are terminal, okay? But I mean, to be the first choice when a root canal needs to be true, when a root canal option, the first choice is extraction. You can't justify that. You cannot justify that with the science today. But can you say, yes, is there potential, some biologic reaction, some problem with that? Absolutely. But the same thing could be said about an implant. Go ahead.
So what I think we should do is one of our guests should be the man who can really lay this all out. That's John Cotomy. And if any of you know him, he's an endodontist, part of the car.
Know the name.
And John will pretty much shut this one down really nicely because it's called evidence-based dentistry. And, so I think it'd be, rather than us even trying to get into it, bring in one of the leading guys in this whole area. He's a good friend of mine, John, and let him tell us, because
I'll be able for this.
When you have a tooth that comes in that has a silver point in it, there's absolutely perfect bone. And a dentist sees this, and you have to replace the crown because you've got some recurrent gingival decay or breakdown of the porcelain or whatever. And they'll go in and say, you have to do a new type root canal on this tooth. Yet that tooth has been asymptomatic and evident perfect for 40 years. Why are we going in and changing something that the body has accepted? So John will really get into this. He would be a perfect person to really open up this whole work, because based on what you were just saying, Miguel, both of you, I heard and I'm not going to say any names, but I had a prosthodontist friend call me about a statement made that it looks like it may be better to take a tooth out than to do a root canal and put an implant in. That's where it's going. And this was by somebody very, very well known in the dental world. And it was shocking. It was frankly shocking to me when I heard that statement.
I would think about...
That's what I'm talking about.
But I will take it back to this point, which is, even though if we use evidence-based dentistry, and once again, disclosure, I have nothing against root canals. I still prescribe them or diagnose them or propose them when we think that we need it. However, you can gather all the evidence-based dentistry you want, but if we're looking at the wrong outcome, then it doesn't matter. So if we in the future, imagine this scenario, we have a different way of gathering data, and we realize that people who have root canal versus people who have fewer or no root canal develop more skin allergy, right? Or develop more immune system, or develop more this and that. And then you go and you create a theory, and you go and sample the periapical tissue, and you see, fungus and protozoa. Those studies out there, I went to Portugal, and I interviewed, for Masters of the Craft, I interviewed Miguel Stanley. And Miguel Stanley talks a lot about this, and we had a long conversation about it, on this idea that because we're looking at the tooth, we'll not listen to a lot of people, patients reporting they had all of these systemic symptoms. They've been in and out of millions of calls and systemic in the hospital for years, until one dentist say, what about this root canal here? It looks perfect by dentistry. And then they go and pull out the tooth, and the patients claim, many of them, I finally feel better.
But that's not science. No, Miguel, that's not science. Okay, come on, man. Okay, that's anecdote, and we should pay attention to that.
No, it's not anecdote. There is science that shows that when you go and sample many of these clinically, or what we will deem a good root canal, right?
Right.
There is a lot of living organisms down there that could potentially harm.
But I would
now again. But I'm not saying that we have
those in your intestines too. Okay.
Sure, but the intestine is the outside of the body. The inside of the bone is the inside of the body. It's a different story.
Yeah, between the bone and the periodontal ligament is outside the body too. Okay, believe it or not. Okay, so it still has to cross the membrane. Okay, so a few organisms.
No, you're in the bone. If you're in the bone, you're in the bone. You have blood. You have stem cells.
Yeah, no. If you're in the bone, I'm talking
periapical. You're in the bone.
I'm talking about between the PDL and the tooth. Okay.
You're in the bone. That's the inside of the body.
We're getting into nuance here. Let's backtrack for a second. Okay. The point should be. Okay, I would push a lot on this, because we all agree, everybody on this forum anyway, we're going to take the minimal amount of healthy tooth structure off and restore.
I'm not saying pull the tooth.
No. Well, let's go back for a second. No, let's go. Yeah, okay. So then at that point, that is extremely aggressive thing to do, to pull a tooth. We lose bone, we lose soft tissue, and all implants aren't 100%.
It depends. It depends what the side effect. If we assume in this scenario that the current way of doing root canal has any negative consequence to it that we're not seeing,
right?
Pulling the tooth is bad if the consequence is mild. But if the consequence is big, pulling the tooth might not be bad.
I agree.
So it all depends on that.
Right. Okay. So the point should be, we should do the most conservative thing that we think is going to give the best chance of survival, just like a small filling, just like an onlay versus a crown, okay? Just like an implant versus a bridge. Just like I'm saying, a root canal that's done well should be your first line of defense versus taking out the tooth. And I'm going to agree with,
but you think I'm arguing that, and I'm not. I'm agreeing with you on that one. I'm not arguing.
Trying to make it clear for the audience out there that the treatment.
Yeah, but the problem is, Ed, that your stance seems to defend root canals a lot. And I suggest that we don't dampen the voices that are coming out questioning the current way of doing root canal, and questioning what are we using as an outcome. That the tooth lasted 10 years, 15 years, is that an outcome? What if there is some chronic inflammation that is creating systemic issues that we're not seeing?
Right. Okay.
So we need science on that.
Yes, I agree. Absolutely. Yeah. Until we have that science and we can demonstrate a clinical problem, something at least, maybe a small biopsy, something like that, okay, before we start condemning a patient to lose a tooth, okay?
I agree. No, today, to remove a tooth because you're afraid of a root canal is not scientific. It seems to be, within dentistry, not scientifically sound.
Right.
However, from outside of dentistry, from more of the medical side, the immunological side, there are professionals that are questioning how we're doing root canals. And I find it interesting. The same way that, and I don't want to get into it, we can do this in another one. Actually, this was a good one for Amrita, Amvita, which is people are questioning fluoride, and it's starting to look like not a crazy questioning of fluoride in dentistry, right?
Okay, I'm not going to do that
when at the beginning it sounds like crazy.
But I can tell you, biologically, you do need some fluoride to form bone. Okay, it just there's a microscopic amount. But you're right, we're probably putting too much on in our waters. All right, so that's another rabbit hole. We got a lot of fun rabbit holes that we can go down here. All right, so what I just like to leave with the audience, okay, is that you always have to look at when you do a treatment, whether it's medical or dentistry, okay. What is the alternative? Is the alternative worse? Even though this treatment may not be the perfect treatment, okay, is the alternative potentially worse? And that should guide your decision, okay? So as much as we love implants, I don't believe that an implant is better than a tooth if the tooth is basically healthy, if the tooth, the root is stable in the bone and we can demonstrate that there's no lesion around the bone, that it makes sense with today's knowledge base to keep that tooth. Okay, all right, that's all I'm saying. Okay, just be aware of that.